Good evening, everyone.
Yes.
It's good night for James, and it's going to be good morning for Shital in USA. And welcome everyone to the first IFICS Master Web Series. And today is Sunday, 14 June. This is 7 p.m. And we have a very interesting webinar on which was named by James as Taming the Patella. He's going to tell you why he named it as that. But what we are going to do in next 2 hours or so is to study what we need to know about managing patellofemoral problems in children. This is something which falls under domain of orthopedic surgeons, pediatric orthopedic surgeons. It falls also under domain of sports medicine specialists and arthroscopists. And we thought it doesn't exist much apart from congenital dislocation patella and habitual dislocation of patella. But the incidence of patellofemoral problem, which are sports related in children, is on the rise. We see many patients, and many of us don't know how to manage it, how to classify it, what investigations to be done. And to clarify all this, we have two international master speakers. The first one is Professor James Hui, who is head of Department of Orthopedic Surgery at National University of Singapore. James is a dear friend of Pediatric Orthopedic Society of India. A lot of us here, including Chintan, Sandeep, and Premal, have done fellowships with him, and they continue to learn from him even now. James has keen interest beyond orthopedics in cellular and molecular and genetic aspect of orthopedic problems. He also has keen interest in patellofemoral disorders and knee sports and knee problems and sports medicine. That's why he is here. And he's going to do the Jugalbandi with Shital Parikh. Now, if you go through Posna Academy, his level of interest and his mastery in the topic is suggested by the fact that his video on MPFL reconstruction is on Posna's website. He's written a number of articles, papers, and book chapters on this topic. Shital Parikh is going to accompany him. He is part of IFICS, and he's at Cincinnati, born in India. Now he's in Division of Pediatric Orthopedics as Associate Professor, and his keen interest, besides pediatric trauma, is in sports medicine. In fact, he's written a book on patellar instability. He has his own classification, and at IFICS Coimbatore, we had a masterly symposium by James and Shital, which we are trying to recreate today. So with this, I also want to tell everybody that good news of IFICS 2020 being organized as a web conference. Probably that's going to be the first web conference in India to be completely online. This is going to be organized in September over 4 weekends, and we are going to show you details of IFICS 2020 once we are towards the end of this program. OrthoTV and Vama Events, they are going to partner with us so that everyone who attends IFICS 2020 on pediatric fractures will experience interactivity, experience knowledge, experience learning with fun like never before. And with Shital's efforts, I'm very happy to tell you that we have already registered. We have confirmation from 11 faculty from Posna, for different segments. Each faculty representing one fracture, which they are master at. And we are really looking forward to IFICS 2020. The registrations for IFICS 2020 have already started at IFICS website, and we will show you the details of how to register towards the end of this session. So without spending more time, I want to hand over the proceedings of today's academic feast to James and Shital. So James, please start. Share your screen and start the session. Till the time James 10 starts, I also want to introduce that we have some young pediatric orthopedic surgeons and sports medicine specialists here to quiz James and Shital. With me are, of course, Sandeep Patwardhan and Premal Naik. So Taral, Sandeep and Premal, that's a trio of IFICS. People call it as Tigide or Tigidi Jodi, and and we like working together. With us, we have Avishal, who is a consultant pediatric orthopedic surgeon at SRCC Children's Hospital. He has interest in hip, knee, sports medicine, and arthroscopy. Chintan Doshi is a person who has worked with both these people, James Hui and Shital Parikh, and I'm sure he is going to ask some uncomfortable questions to both of them. And then we have Dr. Miten Sheth, who is a sports medicine and arthroscopy specialist. He also is a consultant at SRCC Children's Hospital. So I would like James to start with the proceedings today.
Okay.
James, please.
Thank you. Can you hear me clear? Is it okay?
Yes, absolutely. Go ahead.
Okay. Thanks. All right. So look like going to be a marathon session, but I have my companion master, co-author, and co-faculty here, Shital, and therefore, anything I can't answer, he can do it. So there it goes. All right. Why I'm keen on this, because again, I always feel very at home whenever I'm in Posse and also in India, and I always tell people that I don't think anyone in from Singapore have ever been to more than 20 cities in India, and 20 times, more than 20 times more than me. Actually, I can't find another Indian actually from Singapore could outdo me. And these are my fellows, and you could see, I don't know whether you can see Alaric there when he has hair, and then I have more hair. And then there's Anaban and Mihir here as well. So you can see that we fit our fellows very well. And why I'm showing this picture, just to attract more young, budding pediatric orthopedic surgeons from your country to join me in the future. And I really learned a lot from them. And there's Iswa here, and Alaric would tell you that there are only two-way communication between James and his fellows. One is James learning from his fellow. Another way is a fellow teaching James. So that's our two-way communication. So indeed, I really enjoy all their company, and I hope this will continue. And sadly, of course, Kailash was the last fellow who was helping us actually fighting COVID when COVID came here before went to India. So Alaric just sent me something. I don't know where he was. Okay, never mind. He got more when Alaric has a bit more hair there. Good. So there it goes. Why the topic is because I actually I gave this hour-long talk in the grand round in UC San Diego at the invitation of Peter Newton and Dennis Wenger. And Dennis Wenger being very Wenger, so he must some name. Then he said, "Oh, James, but taming the shrew, then taming the patella." That's how we use the topic here. And of course, here you can see that Shital, do you see that a lot of bromance here? You don't see men holding hands like that. You know what I mean? It's very strange. We're shaking hands and we are doing this funny thing. Okay, so there are certain tendencies that I discovered that day when first time I met him. All right, so I always tell people why patellar dislocation is important to learn. Because at-risk population in pediatric orthopedics is at 10 to 17, and really is that our field. And remember, the incidence is 29 per 100,000, and ACL incidence is 30 per 100,000. Therefore, if you are a pediatric orthopedic surgeon, you will see a lot of patellar dislocation. So you need to know something about it, and don't just let the adult sports surgeon who treat everybody from 20 years old onwards. So here, classification. Look, first one, 9-year-old girl asked to extend her both knees. Okay. Classical J sign, classical extension.
Okay, go.
Next one.
Maybe go faster.
All right.
Yeah.
When then you want to flex, you would dislocate.
All right.
Next one.
Yeah, good. Okay. You see.
You extend. Dislocate.
Okay. And now I try to push back again.
Reduce. Flex.
You can go out again.
Flex again. Now already semi out. You can see that like that. All right. So here come in my co-moderator, Shital. Shital has a beautiful classification in Orthopaedic Clinic North America, right? Oh, Shital, you need to unmute yourself, sorry.
Can you hear me?
Yeah.
All right. Well, thanks, James, and good morning. Well, it's morning here, but probably good evening to all of you in India. So I would first like to thank the organizers for setting up this webinar. It should be fun learning. And as James said, with all the fellows and all the students, residents, and young faculty, it gives us a chance to learn rather than teach, because they have fresh ideas and there are no dumb questions. So I would encourage everyone to ask questions. Let this be a little bit more interactive so that we can share ideas. So James was showing different types of instability, and the key thing to differentiate from these patterns are one is that the age that when the instability starts, and that's really important, because younger the patient when instability starts, the more severe their dysplasia is going to be, and their pattern is going to be a little bit more complex. As they get towards adolescent age group and they didn't have any issues till then, and then they start having dislocation, mostly that's going to be episodic. So it could be recurrent dislocations, but it's not like every time they would flex their knee, they would have a dislocation. That typically starts at a younger age. So age is a big criteria, and that's why, as James pointed out, this is a pediatric orthopedic issue, because the more complex patterns of instability are seen in younger patients rather than older patients. So if an adult sports surgeon is treating this instability, he's most likely treating the episodic part. Now, the classification system that we have, it's not a novel classification system. It's not anything new. But the reason to classify was to help with the treatment. Like if you know the patterns, then you go from the mild pattern to the complex pattern, at what point you would have to change your approach to treatment. So when you have a first-time dislocation, a recurrent dislocation, you can do some kind of stabilization. But when you get to habitual dislocation, when you get to permanent dislocation, then you would have to do more than a traditional surgery to stabilize it. So that's how the classification system has helped. And as I said, it's not novel. Like, you go back 200 years and habitual dislocation was there even at that time. So it's nothing new. It's just a way of trying to think about management options. That's why the classification system can help going from 1 to 4. So the habitual dislocations, or a patella which is dislocatable, falls into more complex type 3 classification, and then type 4 is when the patella stays out throughout the range of motion, doesn't come back in. So those instability patterns would need more. We'll go over those, as we see more cases. And the first 2 types is the first time dislocation. 2 types. Second type is 2 or more dislocation. So that's typically seen in adolescents. So that's a little bit easier to manage, because now we have good treatment options and good follow-up and outcome results. Yes, James, we can continue.
Thank you. So I think, no, Shital brought up a very good point. You see, the age where the onset was determined the severity. And that's the reason why every time I went for my patella meeting with colleagues worldwide, they always thought my cases are weird. And the reason is a lot of them saw that cases are very late. And that brings back the point. As a pediatric orthopedics, we actually see the more interesting cases among all. That's why you guys who are interested, sports in the pits are the one really need to know patella well, because patella is something that you one up again over the adult surgeons. Okay, so what Shital just mentioned very nicely about from most simple to most severe. But what I'm showing you here is something very conventional, sort of like published by the books, but nonetheless, we go through, but bearing what Shital say. So congenital or those near birth after that are the one that very obvious, vulgars, and that one very few of us had experience, and most people will have nothing, and really you don't need to learn about this, okay? So next one, so in a way, then come here, the so-called, don't forget my 1, 2, 3, 4, 5. It's no relevance with Shital's 1, 2, 3, 4, 5, because Shital actually put it very nicely about his 1 or 2 is actually like first time dislocator, acute, and then later become recurrent. So very nicely about simple to complex. And then habitual in the old textbook, they will say obligatory. Then every time it flex in flexion, they call it habitual. But today, habitual actually comes in both flexion and extension, and the very high grade J sign, they call it. And the reason why this is important is because this habitual extension, a lot of them are not recurrent traumatic because they are atraumatic, but the patient will have fall and will interfere in the person's sports activities. And that's why, as Shital said, they are getting a bit more severe here. And then finally, in the most severe form will be the one you saw, very chronic, very permanent. So that's how I hope we are not confusing you further, but you think of it, the age onset and how severe things are. All right, so, but this come back to Shital's scenario number 1, the simplest acute case. I think almost every orthopedic surgeon, whether pediatric or otherwise, will have encountered such patient in emergency setting. So came in, pop, the pop sounds like ACL sometimes, and that's what it is. And then this is an X-ray. Do not miss, this is a Shital favorite FRCS X-ray for candidates in Singapore, Hong Kong, UK, all right? And you'll be surprised, still have 40% of them didn't pick up this, on the question, yeah? So very important, so you pick it up, and then you have this. All right, Shital, 15-year-old, fresh, first time, pop, you get this. What should we do?
Yeah. So good. So let's start with the history and with the presentation. So in history, if you look at the literature and if you look at your patients, most of these, I would say 75% of them are atraumatic. That means that they don't have a contact history. It's not because something hit their knee on the side and it dislocated. It's usually a history of them running or cutting or pivoting, and the patella dislocates. So that's an atraumatic mechanism of injury. Sometimes you do see that there was an injury from the medial side and the patella was dislocated laterally, but that's a little bit uncommon. The second thing is that when the patella does dislocate, it tends to relocate by itself in about same 70–80% of the time. So to see someone with a locked dislocation or a dislocated patella in the ED, it's a little bit less common compared to the other scenario of the patient coming in and saying, I did dislocate it, but it went back in 5 minutes or 10 minutes. The reduction is very easy. Like as soon as, if the patient does come in and you have a dislocation, as soon as you relax the patient, if you have to give something for sedation, that's fine. But as soon as you extend the knee, the patella would be relocated. So that's not a difficult reduction at all. And a lot of times, we would hear that the athletic trainer or the coach reduced, or someone's family member or friend reduced it by just extending or pushing it over and then go back in. The most important part is the fracture. Instability, we all know, the patient also knows about the instability that it dislocated, but they would not know about the fracture. So our job first is to find out if there is an osteochondral injury or not. A lot of times you can see it on an X-ray, a very small flake of bone, like you saw it on the lateral X-ray. And a lot of times, if they are chondral fractures, you don't see much. The other thing to differentiate on the merchant view, which was the following X-ray, is this fracture an intra-articular fracture? and this one is. But a lot of times when you have a dislocation, you would see a very small flake of bone from the medial margin of the patella. And that's an eversion fracture. And you should not confuse that with an intra-articular osteochondral fracture, because the small flake of bone that you see on the medial margin, which represents, an eversion fracture from the medial ligament, is an extra-articular fracture, and you don't have to treat it unless it's a very big piece and you think it's going into the joint. So you have to differentiate that fracture, that marginal fracture, from an osteochondral fracture. One of the ways of approaching a patient with a first-time dislocation has been to evaluate the effusion. Now, effusion may take a day to develop if it's a slow effusion, but sometimes, if you have a chance to see the patient the first week, you would see that they have significant effusion. And once they have an effusion, that means that there is an intra-articular injury, and there is a very low threshold of investigating further with an MRI. Since we are, we're part of research projects, we get MRI on all first-time dislocations. But for someone in clinical practice, if you don't have an effusion and you want to just rehab the patient after a dislocation, I think that's perfectly okay. As I said, we get an MRI on all patients with first-time patellar dislocation, mainly to look for condyle and osteochondral injuries, but also we are part of the research. We are looking at patterns of MPFL injuries, and we are looking at cartilage bruising and other stuff. But clinically, it might be okay to just get an MRI on those patients that have an effusion. And I'll just bring one last point. When the first slide that James was showing, that 10 to 17-year age group has a very high patellar dislocation rate. And what we did is we looked at MRI of all patients between this age group, 10 to 17, who presented with a traumatic hemarthrosis. And we did an MRI on all of them. And interestingly, we found similar rates of ACL and patellar dislocation, where we were saying 29 out of 29 versus 30 incidence rate. The only difference was that the younger age group, the 10 to 14-year age group, when we divided them, they had more patellar dislocations, and the 14 to 17-year age group had more ACL. So you can even further stratify it based on age. That younger patient with hemarthrosis, more likely patellar dislocation, a little bit older adolescent hemarthrosis, more likely to be ACL. But in an acute setting, might be difficult to get a good exam because of guarding and effusion, might have to rely on MRI to make the diagnosis.
Okay, so you will fix this, and what else would you do first-time dislocator?
Yeah, I would fix osteochondral fracture. There are different ways of fixing it. My choice has been a metal screw, headless compression screw, only because biomechanically I think it's a better fixation than the bioabsorbable pins. I would also stabilize the patella at the same time, doing an MPFL reconstruction for all patellar dislocations that I'm going in to treat an osteochondral fracture. I do it in 2 stages though. I do my fixation at the first stage and my MPFL after 3 months when I go in to take my hardware out. So a couple of advantages and disadvantages of that approach. One is that, I tell the patient you have 2 problems. You have fracture and you have instability, so you need 2 surgeries. I tell them up front when I see them. So it's not like it's an unexpected second surgery. The second surgery, when I go in to take out the hardware, the advantage is that I have a good look at the cartilage. I know how it is, and whether it's healed, whether I have to trim a little bit, and I'm talking about the osteochondral fracture from the patella, because obviously if you do an MPFL in your first stage, then you have to go back to remove the hardware. You either have to go from a lateral side, which is not optimal, or you have to compromise or go through your MPFL. So I just go do my fixation first and just suture the arthrotomy and then come back and do an MPFL. Now it's a little bit different when the osteochondral fracture is from the lateral femoral condyle. And if I feel comfortable that it's not in a weight-bearing area, it still involves articular surface, but it's not weight-bearing, and I think I might just leave the screws in. I would go ahead and do the MPFL and not come back in to remove the screws, or even if I have to come back to remove the screws, I'm not going to be compromising my MPFL because that's a small separate lateral based incision. So my plan is a little bit different when the piece is from a lateral femoral condyle compared to a piece from the medial patella. The medial patella here, I would do a two-stage. And I would like to know, James, what your approach is for these.
Okay, so I give you some evidence here. So, sorry, there you go. So typically you have, hopefully you get a decent piece. Otherwise you really have to wash it away. And very nicely at the, so medial approach, under surface. And I tend to use a bioabsorbable pin though. I don't like metal in the cartilage. So this is just a personal preference, but we did have patients done before and they seem to be all right in the long term. So, and there's no loss of fixation even with the bioabsorbable pin. All right, so that's how it's like. Then come to the next part where Shital say that he would come in again 3 months later. So why did he choose that? Because, so this is so-called a bit more classic paper just 2 years ago, you know, without concomitant, and I think this is both Swedish and this Arendt group, and then they feel that really getting, especially adolescents with trochlear dysplasia, really had quite high recurrence. That's why you cannot just say, okay, you repair and fix the osteochondral fragment and leave it. But so some of the people say that, oh, you know, if I just, you know, repair versus operative group, you know, last time they feel that, hey, it's not too different, you know, that's why these are the people for conservative, meaning that maybe we don't need to repair them. And then this is a group actually operative repair on all these open fissures. And they find that redislocation rate in the conservative group, only 22%, almost half of that. And definitely trochlear dysplasia contribute. But their repair is not what Shital proposed. Shital actually talking about reconstruction. And because this repair was done in a way acutely while they did the osteochondral fragment. Okay, so Arendt also had another paper all about the similar time. She found that, wow, in all these young age group of patients, really, you know, skeletal immature, some form of trochlear dysplasia, they really had high recurrence if you don't repair them primarily. However, okay, so my group also did that, and we also find that those patients with trochlear dysplasia had high recurrence. However, Shital's idea of reconstruction is probably more recent rather than past, because in the past, the literature, people still try to use primary repair. You know, Shital, they didn't dare to do reconstruction because they feel that among all the hematosis, they can't do it then. But yet they did not wait for 3 months to tell patient, I come in to do it. So I think Shital's plan probably will become more and more, I think, agreeable and more popular, I suspect. So what surgery can be done when people try to repair the first time? So these are various ways people actually can do arthroscopy. And, you know, because for first time repair, you just do your arthroscopic palpation and attach back and just pull back that way. And, you know, with the fragment and all that. And so here it is, this is almost the only paper, you know, Shital in the literature that they do primary repair, meaning really repair the MPFL versus reconstruction, okay? And that outcome was like primary repair have 4 times more than reconstruction. Certainly your point was more valid, and I think when once people work out the system of, look, you do the fixing the osteochondral fragment, but definitely 3 months later come back for recon, then I think that will be very clear to parents, and gradually I suspect people will do that because you know that 42% will come back and recurrence. So, especially if you have seen those with a high grade of trochlear dysplasia, then maybe you should do a recon earlier. So you can see that when you open up, MPFL was very deficient torn, and in very rare cases, for me at least, before I did the reconstruction at the same time, but I find that a bit of mess because, you know, Shital Parikh was fractured, and then I tried to put screw in at the medial side, so not very pleasant that way. Okay. All right. So any comments to what I say so far, Shital?
I have a question. So what are your indications, both James and Shital, for doing a conservative management of acute patellar dislocation? Which are the ones you will conserve? And if you conserve, what are the details of the conservative management? What brace or a plaster? And then when do you start mobilizing, and what is the rehab protocol?
Okay, Shital, you'd like to answer?
Yeah, so you know, the standard treatment for a first-time dislocation for all patients, it is conservative treatment. It's not surgical. We were talking about surgery for those who have an osteochondral fracture. So if you don't have a fracture, so you know you have a patient first-time dislocation, no fracture, and you can rehab them. Now the typical way that I've treated patients, depending on how acutely they present, if it's a fresh dislocation, the first 3 weeks I usually tend to use an immobilizer just to let tissues heal and let the knee calm down a bit. Then I start them in physical therapy to get their motion back, to get a little bit of strength back in their quads and VMO. And then I do use a patellar stabilizing brace. There are different types. You can use a J brace. We use what is called a Palumbo brace. We tend to use the brace the first few months, depending on how well the patient does. And we allow them to go back and do sports at around 3 or 4 months if they have no symptoms and they have passed all the return to sports criteria, which includes hop test, Biodex, which is an isokinetic testing of the muscle strength, and clinically making sure they don't have too much apprehension when we check them, and they are ready to go back. So at the time, we recommend to use a brace with sports, not all the time, but I do recommend that they use a brace when they're doing sports. Now, this is not a very standardized protocol because we just finished a survey of the PRISM group on first-time dislocation, how their approach is going to be, and the rehab or the duration for immobilization, the duration of brace wear, the time to return to sports, physical therapy, and how long therapy, it was very variable among physicians. So there is no standardized treatment. I'm just telling you my approach, but there may be different protocols for therapy for getting them back. But typically 4 to 6 months is how much rehab you would need, and then they can get back to sports. The more important question is, is there a way for us to predict which of them are going to fail? And so that's entirely a different topic. I don't know if James has any further slides or discussion related to that. Then I would leave it there. Otherwise, we can discuss like how can you predict which of these patients might have recurrent dislocation.
Yeah. So as I say, those paper in Elizabeth Arendt show that patient, especially various degree of trochlear dysplasia, seem to be the highest risk predictor for recurrence. Yeah.
Can I ask a question?
Yeah.
So in your primary treatment, do you have any algorithm and preference how soon which investigation should be done regarding MRI, CT? Do you prefer to get it on the same day, or how long can you wait to get it done? Do you have a choice or a timeline or something like that?
I order it when I see them the first time. So usually it's done within a week, and I can get them into the OR within 2 weeks from their injury for the osteochondral fracture. I think that's reasonable. I've gone in as late as 1 year to fix an osteochondral fracture when the patient presented that late, and the issue is that further delay you have, the further mismatch there is going to be between your progeny and your main fragment, because the fibrocartilage fills in your defect, which gets smaller, and the piece, because of the synovial nutrition, would get bigger. So your mismatch is going to increase. So if you get to it acutely, your fixation is going to be very good, very anatomic, because you would have some fissures that you can align. You'll have some spikes that you can wedge in. So you have good fixation if you go early. The later you go, you have a mismatch. It might be a little bit difficult, but my goal is to get to fix it at the earliest possible duration. Usually within 2 weeks, I would get to it.
Shital, the two questions from Tushar Agarwal from Bombay. One is that is your osteochondral fracture fixation, what do you prefer? Is it an open method or arthroscopic? And secondly, if you don't do MRI, how many percentage of acute patellar dislocation would actually have osteochondral injuries and you may be missing them if you don't investigate?
So to the first question, arthroscopic, so I do start with knee arthroscopy and I retrieve the fragment and evaluate it, because a lot of times, the fragment may be bigger than what it appears to be on an X-ray or even an MRI. The second thing is to judge the quality of the cartilage, whether there is a lot of fissuring, whether it's badly bruised cartilage. And if the piece is less than certain dimension, for me, it's usually around 15 millimeters, then I don't tend to fix it back. I would discard it and I would just do micro drilling, which could be done arthroscopic. At the same time, if there are pieces, intra-articular pieces and multiple pieces, I've also left them, because by the time I've gone in, they've been they're already healing to some synovial tissue out of the articulation, so it's not going to come in the joint, and they just get absorbed, or at least fibrosed in the synovial tissue. So it depends on the size of the fragment, but typically my goal is to fix it if I can. So if I have a bigger fragment, a single fragment, good cartilage, then I would do an arthrotomy and fix it anatomically. But if I don't have a good fragment, then I would just do arthroscopic treatment. I would just remove the fragment and I would micro drill. I would drill into that bed, cause microfracture, or sometimes even leave it. I would not. The piece sometimes has started to heal to the lateral aspect of the femoral condyle or to the synovium, and I would just not touch it. If I don't think that's a big enough piece. The second question, the osteochondral fracture rate has been very variable in the literature depending on what you read, anywhere between 15 to 35 to 40%. A lot of these osteochondral fractures, may be really small fragments. So if you miss it, it might not be a big issue. The main issue is if you have a big enough fragment that you miss. Okay, so sometimes it can take 1/3 of your patella, and if you miss that, then that's an issue. So a lot of these fragments you would be able to see on one of the two views, the lateral view or the merchant view. So even if it's a very, it's mainly a cartilaginous piece, you would have a single layer of bone covering it. So you'll be able to see it. It's just carefully checking your X-ray and having a very low threshold of getting an MRI if you have knee fusion, because there is going to be some intra-articular injury. So my recommendation is if you don't get an MRI, just evaluate the X-rays really carefully. And if you have an effusion, do get an MRI.
Yeah, James, we can go ahead with your slides.
Okay, so let's move on about, so when Shital mentioned about acute and when will be recurrent, so if here comes the next severity in classification in recurrence. So in the moment you go into recurrent, and that's where Shital will say, how do you predict? And also here, then you really have to look at this patient as a whole. So there you go. then as a pediatric orthopedic surgeon, we are more qualified than anyone in the orthopedic world in assessing this sort of case, because we have been trained to look at version, length, angle all our life, right? Because unlike surgeon who deal a lot of ligaments. So here we are, excessive femoral anteversion, you need to look. And the top also trochlear dysplasia, you need to see. And classical femur angle, then you get genovalgum. Then come down, look at the patellar position, whether it's alter. And coming down further, you see whether there's excessive tibial torsion and whether the TTTG has increased. So you can see a lot of things you need to look. And with those you look, then you can, while dealing with such patient, you bear in mind, what can you do to correct them? So I found that I make sure my residents will really go through all these so that they know femoral torsion, I can do derotation, trochlear dysplasia, I can improve stiffening, I can correct genovalgum, MPFL, you can reconstruct, patella, you can distalize it, tilt, tight, you can release, excessive, you can derotate, and TDTG can do a TTO. So you can see a lot of things you can do once you know, you have found out and what are the risk factor and this patient go into recurrence. And then people will always ask you, oh, when do you do something proximal? When do you do distal? I tend not to think of proximal or distal. I tend to think, really, if there's a problem proximal, I'll address distal, there's problem I will address. I will tend to address all of them once it dislocate. So, a lot of work on patella dislocation, but she's an adult surgeon, very interested anything to do pediatrics because she felt that our things are very much more severe than hers. And she had this nice algorithm in JBJS America, very well cited paper, and she used different criteria and come down. Then you see here, she used a very nice, just like Shital's earlier say, age matters. So really remember age matters. And here she used all the classification, then she come here, she give all these skeletal immature patients and what I look for. So I think this is one graph, something I feel very useful as in other than the model I show you, this is something that she used in her patients, in immature patient, simply because you tend to have higher yield in this group compared to that of adult patients. So you can see that coronal malalignment, and then she actually used guided growth and check your rotational malalignment, which I mentioned to you earlier on. Look at the femur and also MPFL, and she mentioned LARC and modified Rugo wave here as well. So this is something in immature, I will go through a little bit more as we come down. So very classical in the immature patient, Q angle, you can see that. These are the group that very obvious, patella sublux. And we're fortunate to have enough cases to have done hemiepiphysis to correct these patients with patella subluxation in that age group. We use guided growth. They usually have a clinical J sign and CT patella to prove that, and a lot of them are bilateral. So the beauty is you can do either just distal femur or in more severe cases, both distal femur and proximal tibia. So my question for Shital is, how reproducible do you think this technique is for this group of patients?
We have to look at the patient as a whole, like, starting with their alignment and rotational profile. James did show a slide with all the potential, risk factors, starting with anteversion, patella alta, and TTTG. My question is that what would you do if you have all of these? Okay, yeah, I've seen patients who have a femoral anteversion, who have increased TTTG. If you have, instability, they have a little bit of valgus, and they have patella alta. Are you going to be doing all these surgeries in one patient? Or how do you decide like which surgery is more effective than the other? So my algorithm for treating these patients is that my MPFL reconstruction, now we are talking about episodic dislocation, not the habitual dislocation patients. So for these are adolescent patients, 13, 14 years, had, maybe 2 or 3 episodes of dislocation. My algorithm is to do an MPFL reconstruction and then combine them depending on the risk factors. So they may have a lot of risk factors. They may have a severe trochlear dysplasia. They may have patella alta and a tilt. So my algorithm is to do procedures which are less morbid compared to more severe. So if there's severe dysplasia and maybe say patellar tilt of 20 degrees, I would have no issues doing a lateral lengthening or lateral release to address the patellar tilt, but I would be reserved doing a trochleoplasty, even though both are risk factors. And actually, trochlear dysplasia is a major risk factor, or it's one of the most cited risk factors that is going to be predicting recurrence or failure of your surgery. Even then, I don't address it during primary surgery just because of the morbidity of the procedure. Same thing is if there is an adolescent who has genu valgum, whether I can do an osteotomy or whether I can do guided growth. Now, these two are morbidity significantly different. So my threshold of doing guided growth is much less than my threshold for doing an osteotomy. So if it's a 10-degree valgus in a 12-year-old, I would do guided growth. But if it's a 10-degree valgus in a 16-year-old, I would not do an osteotomy because osteotomy is more morbid. So I choose procedures which are less morbid, or not based just on measurements or based on the presence of risk factors, but what procedures I can do easily. So guided growth is easy for us. So I would have less threshold. Anything which is more than 5 degrees more than the other side, I would do a guided growth. But for osteotomy, my threshold is more. I would wait for for it to have 10 degrees of more valgus compared to the opposite side before I consider doing an osteotomy. So I do combine, my MPFL with lateral release or lateral lengthening. I do combine them with guided growth. Sometimes I would combine them with tibial tubercle osteotomy, but for me, doing, derotational osteotomies or doing trochleoplasty are only for those severe cases. So I've seen a lot of younger patients with anteversion. I would not do osteotomies for them, even though they're, based on cutoff, because we don't have a proper cutoff. You can say it's 13 degrees or 15 degrees of anteversion, the cutoff. I've seen patients with 20 degrees of anteversion, and it's physiologic for them. So I would not be too much, inclined to address all the deformities that are present in these patients, but choose the ones which are less morbid.
Okay. Actually, Shital, you went ahead of my question. Actually, I want to ask just how reproducible about guided growth. That's my main question. You actually went ahead to my other.
I would do guided growth. I think it's a very reproducible as long as you know that you have growth remaining. As you said, if it's more severe or less growth, I would do both femur and tibia. Otherwise, if you have more growth remaining and your deformity is restricted, I think it's very reproducible. Of course,
okay.
Well, I do it a little bit differently than the plate. I use transficer screws, but that's just a technical issue.
One question for James is, James, if you've done guided growth and if your deformity is corrected, what about the patellofemoral problem? Does it get sorted out on its own, or do you need to do further procedure in some of these patients? How do you do it?
In those quite selected group of patients, we end up having very nice CT scan showing post-op, after a couple of years when everything straightened up, they have centralized and also less and less dislocation. So, and that's where probably may not obliviate all the way. That's why I asked how reproducible, because I found that they decrease the incidence.
Oh, sorry, I think James, so if you are asking how reproducible is correction of genu valgum or guided growth to correct instability, then I would say that I don't have much experience, because I have not done just correction of genu valgum for instability. I've always combined it with an MPFL. And so I will tell you the reason for that, not just addressing the valgus for instability. One is that it would take, more than 6 months for the valgus to correct, and I don't want the patient to be subjected to more instability during that time frame.
Okay.
The second is, if you look at the paper by Mosca, where, they did 20 patients, I think, or just corrected genu valgum, you see half of them had recurrent instability even after the correction was achieved. And then 1/4 of the patient had positive apprehension and continued to have, instability issues, like not frank dislocation, but they were, they had apprehension. So I have never just if someone presents with a valgus and genu valgum, instability and genu valgum, I've never just corrected genu valgum. I've always combined it with an MPFL reconstruction.
So as I say, in our paper, no, that's exactly why you mentioned that, because in literature, really not many people did that. That's the reason why my paper got accepted so easily, because otherwise only 15 patients are such a small number, but they readily accepted it. And the reason is why I asked you about reproducibility, because I found that a lot of them did decrease the frequency, but like you say, there's still apprehension and still not totally clear. But nonetheless, because the morbidity associated is so small, I was more keen to do for that group of patients. Yeah. All right, so let's continue on about coming down when you assess a skeletal immature patient. And this is some concept that I like to, we talk so much about TTTG, but really very few TTTG are really known in pediatric patients. We all know that beyond 20 must do something, but I think very few of pediatric orthopedics, if I ask them, hey, do you know what's a 9-year-old normal TTTG or not? Probably very few people will know. So, and this is something that you can see that almost using a guide of like, they 58th percentile, it go about till after 9 years old as 9 millimeters. So after that, sort of like, beyond that, sort of like plateau off. So just remember, so about 9 or 10 is the cutoff for the so-called norm, but for you to do anything beyond is had to be like 97 percentile, therefore 20. So you can see that for kids from 9 onwards, then this is where TTTG is sort of getting very significant if you have very high TTTG, so they stabilized.
Okay, go.
So case,
Maybe go faster.
we mentioned that earlier on. Okay. So now case 2, now we address this very specifically. Habitual dislocation in flexion. All right, every time, or you can call it obligatory, every time patient flex the knee, you dislocate. So Shital, how do you assess and what will you manage?
So first is, we always start with, the patient as a whole, just make sure if they have any syndromes. A lot of these patients may be syndromic patients, and you want to just evaluate. And if this is the first time they are seeing you, it might be okay to get a genetic consultation if you are concerned about a syndrome that is not identified yet. Also check the contralateral side, because a lot of these patients are bilateral. So, you want to make sure that, that you check the patient as a whole to address the habitual dislocation in flexion, which has more dysplasia compared to the habitual dislocation in extension. They would have short quadriceps, they would have lateralized quadriceps, and they would have tethers on the lateral side. So my surgery, which is like a 4-in-1 quadriceps plasty, is first to start with the midline incision. I do a lateral release, which is very wide, to take out all the tethers to the iliotibial band, and cut off the vastus lateralis tendon. I would just tag it for later reattachment, and all the way down up to the tibial tubercle. So wide lateral release, and then I would do a medial arthrotomy as well, and that's just my technique of doing a quadriceps plasty. It's based on Insol's technique, which was designed for total joints, but I found it useful in my patients. I would almost always I would do a Rugoldt weight on these patients since they are younger patients and you can't do a tibial tubercle osteotomy on younger patients. So I would do a hemi-transfer and then if needed, I would do a quad lengthening. The younger the patient when they present, more chances that might need quad lengthening and a little bit older patients, you know, I have been fortunate enough to get away without doing quadriceps lengthening in most of the patients. Once I do a medial and the lateral arthrotomies and I reposition the patella, bring the medial flap over to the lateral side and suture it along with the Rugoldt weight procedure. I do not do an MPFL reconstruction along with this, though there are reports and some do recommend doing an MPFL along with it. But I feel very comfortable with my, you know, quadriceps plasty, so I have not done an MPFL with it. You can judge, you know, the need for a quadriceps lengthening based on, you know, intra-op assessment. Once you get the patella onto the trochlea, you flex the knee, and if you can get up to 90 degrees, then I would not do quadriceps lengthening because over a period of time, it's going to stretch out. My concerns with lengthening is an extensor lag and, you know, long-term weakness, which would be difficult to rehab. And that's why I kind of, you know, just reserve it for those who have significant shortening of the quads. But that is approach. The main thing is that an isolated MPFL reconstruction is not going to work. So don't try to, you know, extend indications for an MPFL reconstruction. It would work only if your tracking is okay. So once you have an adequate tracking, you can do an MPFL reconstruction to prevent the patella from going out, you know, for every patient. But you can't expect the MPFL to pull the patella in or to work in these situations.
So this is a classical kind of case that appear in pediatric orthopedic practice, I feel. And I'm so glad you mentioned that. To me, it's really quads and lateral complex is the main issue, and not your MPFL and or anything else that the adult sports surgeon will do for this. And I'll just show you what we deal with this. And typically, in this case, was unilateral, and those bilateral cases are the one tend to be syndromic, and like such as nail patella syndrome, and I have 3 such patients, bilateral and nail patella syndrome. Very nice patient turn out that way. And this is what's like. You can very classical, whenever you flex, you get a CT scan, you see this, and classical patient will appear this way. You know, this is just unilateral again. And all these are the so-called technique described, but just stick to Rugoldt weight, because this so-called Galeazzi is actually, I would say, you know, Shital is the father of MPFL, you know. So Galeazzi was damn clever. Before MPFL by sports surgeon, Galeazzi actually described this first, okay? So pediatric surgeons are more, so this was like Rugoldt weight, then you put the tendon underneath and pass across. And so this patient's quite young, and what Shital say, you could do after you quite nice thorough release, and without doing quadricep plasty, just Rugoldt weight, I managed to flex more than 90 degrees. Therefore, spare me having to do quadricep lengthening. And you can see that, make sure that you have, must be able to flex to 90. Otherwise, next time you get recurrence, because if you flex less and then you cast it or brace it, patient will not have the length totally corrected. So, and the beauty about our kids is that even though with 90 or 60 flexion, they seem to have no quadricep weakness or lag after that. I don't know whether it's the same as Shital's experience. So, but in certain cases, you can see this a bit older kid. Having done that, I find I need to do plasty, and this is where I need to do. And it is also very cute. You know, when you talk about why you need Rugoldt wave, you talk about acute angle, Shital, you look, when you flex the patient, you can see how laterally the tendon is inserted. It really give you like this is called TDTG, but also what you call as if it's like a quantitative Q angle here for you. The effective Q angle appear here. So this one we need to split and past the tendon underneath, and then get to suture onto the periosteum, and you can even use suture anchor if you don't feel strong enough, and you do a BMO advancement at the same time. And I think Shital was concerned about patella being sort of like open up, right? If you don't do this procedure well. So it's something you need to worry when you final suturing. So this is very nicely, very strong complex, you know, even though it's just tendon attached to periosteum, but surprisingly, it's extremely strong. So that I did not have a single rupture in my life. So it's touch wood, quite lucky that way. All right. So, and that is for immature patient. You know that's a problem with TTDG. And then, of course, if you recurrence, MPFL is the workforce. So we have no choice but have to comment about MPFL. So MPFL in children is something special. And I think our good friend here is all the group of prison people, Kevin and Ted with Shital together. And this, they did a lot of cadaveric study. I don't know, Shital, how on earth you guys can get cadaver in children, children's knee? And then
yeah, that's interesting. We didn't have it, but you know what we did is there's a company that provides us with the allograft, you know, and we all came together. You know, it happened that, you know, it was independent effort by some physicians, but then everyone realized that we all need cadavers. We all came together, and so every year they reserve, or you know, so it's only one place, you know, where they keep all these, you know, in Denver. They have this lab, and so anyone, you know, any kid, a cadaver knee that they get throughout the U.S., they just keep it for us for, you know. So the dissections have been going on every year in pediatric knees in Denver for the last 7-8 years. So if you independently try to do it at one center, that's not possible because, you know, the rate of procurement is so less. But if you combine with multiple physicians together, everyone who is interested, then you can get pediatric knees, you know, or whatever pediatric specimens you need for dissection. That's the only way to get it, is to have a central site for collection.
so this is really amazing because they allow you to know where exactly your physis is and where's the safety to put in MPFL suture, anchor, or screw. And nice study by Raymond Lu from Cleveland. And knowing that if you do your kids for MPFL, if physis open, try to drill it distal to the physis and also going in the angle, so degree 15 degrees anteriorly and distally to avoid hitting the physis. And why is this important? Don't put it like the typical Shital's point, you go it proximal to the physis. If you do that, as the child grows, you find that your whole thing get migrated further and further up. So you need to do this. This is something, if you deal with pediatric MPFL, something you need to bear in mind. So that's how it's done. I film, you can see angle a bit more anteriorly. So this is procedure. I just go through very quickly with you guys because I think Shital and I actually had done a demonstration in Ganga Hospital 2 years ago, but we just go through this.
It doesn't go more than 1 centimeter.
Actually, this is one I did in Posner Academy, I guess. Yeah, to see first, make sure there's no, to see the degree of lateral subluxation, and do a scope to check how sublux it is. And then step harvesting of chrysalis. I don't use semi-T because I feel semi-T is wasted for MPFL.
Okay.
And usually try to take a tiny tendon and try to be as small as possible. It's very thin, but remember MPFL are for restraining. We just put there as a stopper. We are not like ACL, it need to be so strong. So I tend to use chrysalis. But of course, sometimes you can also harvest it posteriorly for the light. I don't know whether Shital does that for the light of a beauty of a cosmesis. And I learned that some New York surgeons do that too. And this is someone I took, just happened to be, who came back 1 year after surgery. Shital, I took her picture of harvesting just to show how cosmetic it is for girls. I don't know, do you do that?
I always harvest on the posterior aspect for MPFL. Yeah.
How interesting! Like, I mean, we didn't learn for anyone, and then we didn't even read literature about this, but yet we would think of this and in a different part of the world, and then did the same thing. Okay, so we make sure that we have good ends, and now the medial incision for the medial border patella. 3 layers identified: skin, retinaculum, and capsule. I guess this a bit dry when I talk like that, because I think nothing beats when Shital demonstrated in Ganga. You know, you really get to see everything live. So I'll probably meet you all next time there and get to the second layer, and then you can see, make sure you dissect out 3 layers to be seen, and the medial tunnel must be created between layer 2 and 3 to reach the medial epicondyle. And you prepare the graft, prepare the site, and I tend to use a wire to make sure before I start drilling them. So I want to get everything perfect on patella. And I don't know, is that Malik's hand on my fellow before? Okay, and make sure you do this X-ray, must be perfectly lateral. And I think Arthrex even have a measurement for you to just get to that Shital's point. And this is how it's like. Then you drill in, you get your patella 9 to 11 o'clock and Shital's point. And this is how we prepare for both sides. And I tend to use the same technique all the time. So Shital has a bit different. I tend to use 2 limbs and patella, and I drill into it. Yeah, this is typical thing I did. This is sort of like, this is 9 and 11 o'clock. And then, so 2 limbs. And after that, you can see that the tendons onto the patella. Okay, never mind, a bit too slow. Sorry. Just to put on, and then, you know, Chintan and Malik are very good, and Kailash are very good in doing this part. So with 2 limbs. And then make sure the length is good enough. And then you always create this tunnel very well, so that so you can pass down, transfer into, sorry, you can see that very nicely created. And then the tunnel to pass under. And then, okay, that's pass into one. And after that, you create your femoral tunnel. And then, and before you do the final fixation into the femoral tunnel, always do this scope of the knee to check your MPFL is extra synovial. Yeah, you know, when you do this too many times, at first you think you're so good, then after a while, oops, you may get surgery because we find the tendons inside the layer, you know, and not very nice. So after that, you fix the graft on the femoral side.
Are you comfortable, Andrew?
And then
Andrew,
this
not
part,
much
I always make sure the patella is not, because, you know, like ACL, as you tighten the graft, sometimes the graft gets pulled in, and then your patella will tighten. So I'm very sure that make sure the patella doesn't go too much medially. Remember, it's just a stopper and not like ACL to be so strong. Okay, so this is the final screw. So you can see that my finger always on the patella. I'm so worried about over tightening and iatrogenic. And of course, alternative, you can do tightrope as well. And that's the end. And
90, go to 90 degrees.
Make sure you go to 90 degrees. They always say that if you break, it's better to break now than later. Yeah. Okay, so that's my MPFL technique. Any comment from Shital?
No, I think it's very similar principles. I think I would just be I would do it a little bit differently, but not in principle. It's just, you know, fixation and implants and everything would be anyone's choice. I don't think even the graft, has not shown any difference. So technically, I don't think, whether you, use anchors, whether you use interference screws, whether you use a bone bridge on the patella and same on the femur, as long as you get your anatomic attachment points and you get the tensioning, that means, the graft. Ideally, MPFL is not supposed to be tension at all. You just flex it, and wherever the patella sits, you just fix it there, so you're not pulling it one way or the other.
Yeah,
So
fact,
as long as you manage the principles, I think I would agree with everything that you said.
Yeah, in fact, you should always, they say you should put a little bit loose rather than tight. So very, very important about that. And I tend to do the same technique because I don't want to have different thing in the end when fellows came and everyone get confused. So I try to stick to the same one. And fortunately, till now, with all the biopsiable screw that I put in, I had not had a single patellar fracture, despite my fellows put in all the screws, so that's something is quite commendable.
I want to again re-emphasize the point which both of you have said, that this is one repair or reconstruction where you don't want things tight. Orthopedic surgeons want everything tight from TKR to ACL. This is one place where you just want to leave it in place and not keep it tight.
Yeah, that's correct.
So here come down, then you address the problem proximally MPFL. So come to, if you're skeletal mature patient and not Rugo way, but TTDG and normal, what do? So again, something that once they're normal more than 20, I tend to address them at the same time. I don't want to do MPFL isolated when the TTDG is more than like 22, 23. So, so there's a patient, and that's why my typical technique. I think probably my fellow is most sick of this technique because we did so many of this. I think overdid. And M3 Trilla, and Shital, I measure everything. It's crazy. Like, must be the tip 1.5 millimeter and below another 1.5 millimeter. So everything I have measurement, so that the fellow and resident, I just stood there so that whatever they do, they follow my measurement. So then nothing get broken. You understand? So like crazy. And even this, I also measure 1.5 centimeter down. So measure it down. Okay, stop there. All right. So then it's a guide wire to guide first. So this is essentially more like M3 Trilla. So you don't need to cut from lateral deep medially like what you've done for, let's say, Ferguson or otherwise in those PFOA patients and the saw and so you don't. I just use a saw to start the near cortex. After that, you use the osteotome to cut across, because osteotome is much less traumatic. And remember, I always like to preserve the far cortex, medial side, all the blood supply. Yeah, so it's beautiful. You open up so nicely. You open up gently, nothing get cracked, and all the blood supply is still there. And then again, everything measurement, 10 mm, 12 mm, you shift. After you shift, put a wire down, so everything stay there, and then put on the screw. So everything, no one get too tight, and everything put in, and just 2 screws. It's a simple procedure, but if you go wrong, can go horribly wrong, because remember, only 2 screws. And if you don't do the 2 screws properly, you may have fracture, you may have displacement and non-union, all that. And again, I was very fortunate. Shital, I had not have a single non-union nor fracture. So just and again, all cases are done by fellows. So it's something I'm very proud of. I mean, the technique is very reproducible. Yeah. So you can see that the shift can be, look at that, very nicely translated. Beautiful, like can be 15 mm, very strong, and the patient get to walk straight away next day. So MPFL and the TTO at the same time, they full weight bear next day, just walk out of the hospital. And final position, yeah. So third scenario, okay, sorry again, Shital, any comment on the TTO or M3 Trilla?
Well, I do it a little bit differently in the sense that I angle it a little bit like an entromedialization than straight medialization. I do use 2 screws, 4.5 bicortical. I do tend to, make sure that they are, not sticking up, a little bit. I would like to, one of the, common complications of doing TTO is hardware removal, is to, because the screws are prominent and, so you always countersink.
I remove all the hardware. So at the same time, I get to see the scope, you see.
Oh,
sorry.
Okay. So I don't, remove the TTO screws. So they are countersunk below the tubercle so that I don't have to remove them. Otherwise, they can be prominent and painful, if you kneel on it. So other than that, it's, and I usually don't move it more than 10 millimeters. So, I do a, pre-op TTTG, but I don't move it more than 10. That's my threshold of moving it. But other than that, it's pretty much, my cut comes from the medial side, medial to lateral, because I'm on a downslope, because I'm angling it, versus yours was from lateral to medial because it was straight cut.
Because you are really doing like a focusing, like,
yes, but not too much. Like, I don't angle more than 30, 40 degrees. So it's not, my purpose is not to offload, but I still like to enterize a little bit.
Yeah, for me, if I'm doing my adult cartilage patient, I will use that technique. So I
yes,
cut a huge chunk going down. But these are the adolescents I found. Remember, Amsri was originally described for adolescents by French. So, and I feel the Americans are overkilling it with focusing for kids, So that's how I feel.
Yeah.
Okay. Never mind. So I move on. So case scenario 3. So now move on to not just a simple and recurrent, but a little bit more severe. So you can see this is a 16-year-old female. Okay. So you see. Okay. So these are the kids that really, when you see their X-ray, they're like that. They're like this. Okay. So fortunately, there's no valgus, no malalignment, I think. But so this is if all the young surgeons' favorite, okay? All your crossing sign, double contours, supratrochlear spur, everything, name it, you have it. So you love this sort of thing, all right? Because why? The CT scan will look something like that, okay? Why you get your double contour? Because everything goes wrong. Why you get your spur? Because everything come out here. So beautiful. So these are the classical cases in a high-grade J sign, habitual dislocation extension, and trochlear dysplasia. So all you need to learn about this, double contour sign, crossing sign, spur. So then you come back again, like what I mentioned, the model. You evaluate the patient, proximal, distal, medial, lateral. So you look at them. Anywhere is tight and they loosen, and anything is insufficient, you have to do something. And here we go. So you can see the MPFL really insufficient here, and then there's a trochlear dysplasia and also increased TTTG. So Shital say, what's the risk benefit of doing a trochleoplasty? You know there's a trochlear dysplasia. Why will you do or will you not do? So Shital, my indication for trochlear dysplasia is really patient literally had to ask for it, meaning on table, I really had no choice. The huge bump, and if I just done TTTG and TTO and MPFL alone, and natural release, all that, and you can see the whole thing just flipping away, then I will do trochleoplasty. So I'm really, it's like the last option. It's not a default option. So I acutely aware how morbid it is doing trochleoplasty. So this is a man, Joe. So we're on faculty together with Aran on the whole thing about this. So the same question that she asked: MPFL, TTTG, trochlear, and CD distance. So how would I deal with that patient? A long midline incision. I use a TTO to serve as opening, so that you have a very nice open as an access point for trochleoplasty. And go here, you look at this. I mean, you agree with me, right, Shital? Such patient, yes, I think, because yeah. So So I do them, but all my fellows know I only do this type. And in fact, a lot on table, I want to show them, then we're debating. I told Chindan, I said, oh no, I love to show you, but do you think should we do, should we not do, you know? And in the end, I'll chicken out, you know, I'm quite a catty cat. So I actually only do type D, okay? So because as you know, you take the hinge, I use the guide wire first. If you do any of this, you really have to go to the lab and try to practice first, yeah? And then you create a huge trough underneath, so groove deepening and preserve the cartilage on top. And this is a nice device by Arthrex, 3 millimeter, and then you get to thin out the thing, and they make sure that you will not break the cartilage. And I call the iPhone translucent test, shine from the side to see how loosen am I. So you can see that it's very uneven. I don't dare to do such a thorough job because I found that too thin, I end up cracking the thing. But too thick, you find that you cannot press the cartilage down. So finally push it down. I use a biopsiable pin, and then you can see the correction compared to before. And there's a final. Usually by then I do let go tourniquet because my operate time is too long. So it's very, very stable. And you can see post-op X-ray, did a TTO, a long one, and then MPFL, and then you see the cut of tracheoplasty, and here the healing. And you can see that, you know, some be nice, some you find that, you know, the bump, you know, because when I left a bit more bone here, I cannot press all the way down. And some people, they say, oh, just leave the bone here, just press the middle. I'm not so sure whether that's such an idea. I prefer it to be as even as possible. And what's so interesting thing is that I did this together with TTO. You know, Shital, very funny is that some people say that, oh, tracheoplasty, as long as I change the trochlear groove at the top and a bit more laterally, therefore, I effectively change the TTTG distance. But when I study their cases, and I always ask them, show me the post-op CT scan. And I found that it's not as nice as they say in the conference, okay? Because when I asked them for CT scan, because I knew it because I did it myself, I had to do both tracheoplasty and TTO, only the whole thing get the TTTG got corrected, yeah. So, and this is, you know, that's where I did, Shital, when I come back to remove a screw, then I get a chance to ask patient to do a diagnostic scope for me to look at the tracheoplasty cartilage. And you can see that really it's not as nice, as pristine as a native cartilage, you see. So something that I'm acutely aware and of the morbidity. So any comments from you so far?
No, that's a great case. I think, you know, my indication for trochleoplasty is usually for revision cases, but in this case, I would agree if it's, you know, significant type D trochlear dysplasia with the habitual dislocation, you don't have a choice but to address the trochlear dysplasia. So the only thing that you said is I usually don't combine it with the TTTG, as I try to adjust it a bit on the trochlear groove side when I'm doing trochleoplasty, but and my fixation is with sutures rather than with the screws or pins. You know, one the thing that you have to be concerned about, you know, these patients is stiffness. You know, they all have some stiffness post-op, so you have to be careful about rehab and starting them early on with motion.
But we are quite lucky because I think our patients are very young, like 16, 17, and yes, they did not get stiffness somehow. Yeah.
Yeah. No, I've not had any issues with stiffness from trochleoplasty, but that's what has been reported. I start them very early in rehab.
What's the rehab protocol, Shital? You know, all of us want to know after trochleoplasty because, you know, there is going to be pressure and you don't want the raised bone to collapse. So what's your rehab protocol? Both James can say, how did you manage the rehab in this patient?
Oh, okay. After tracheoplasty, I'm a bit more, not like MPFL or TTTG. That one I just walk straight away. Here, I actually send patient for home CPM. We are very lucky that because my cartilage repair program, I had home CPM, 15 Singapore dollars per day. I think it's damn cheap even by Indian standard. You know, it's like all my friends from US, when they say home CPM, like 50 US dollar per day, right? Is that minimum, right? Correct, Shital?
Yeah, that's correct. It's not as cheap.
Yeah, mine is like only 11 or 12 US dollars per day. And it's very, very nice. And they do that CPM so that make sure, especially first 3 weeks and no weight bearing. Then after 3 weeks, then allow them to have a progressive weight bearing.
So even if you don't have CPM, it's okay to do it. It's just that you need to start earlier rehab. The advantage of earlier rehab is nutrition to the cartilage, and the force of the patella also keeps the flap down rather than thinking the other way around, that if you try and mobilize them early, you might just lift up the flap. It's actually the pressure of the patella is going to keep the flap down, allow it to heal better. I would start with motion soon. You know, weight bearing, you can restrict them till they get their quad strength a little bit better. So the first 2 or 3 weeks, they can use crutches to ambulate, but motion-wise, you don't want to immobilize them for too long. Like maybe use an immobilizer to control post-operative pain. But I usually start them in therapy just in 2 days. You know, start moving it.
Yeah, Ashita, my comment on the suture technique was that, again, I've seen colleagues and I myself also use suture. I found that when I do post-op CT, it's really did not compress as nicely as the bioorthopaedic screw.
Mm-hmm.
Do you experience? I don't know. Do you do post-op CT or?
Yeah, so you know there are different ways. So you know the way that is been you know published is that you put an anchor just above the notch and one anchor superior to the trochlea. I also use the third anchor in between, right in the groove, you know, and that keeps it flush down. So I use, you know, not in the middle. I don't just use 2 anchors. I use a third anchor in the center, and that keeps the flap down. So you know, a little bit technical modification, but that helps to keep the groove in.
So Sandeep, this is what the Singaporean call it kiasu, and then look like this Shital is doing the same thing, you know, like double protection. Terrible. Okay, good. So the beauty is this, when you know, you can see that post-op cases where you can see how beautiful. Again, you know, parents will be tremendously pleased because the operated side, you know, doesn't dislocate and the unoperated side is there. So they usually love you after that, provided there's no complication. All right. So now move on to clinical scenario 4. I think we only have 20 more minutes to go. So this is something, you know, add on even more this. Okay, so this is just a fun part. Maybe I just go through quite quickly. You can see that more problem. So CT scan, and then you get extension, and then you have, when you analyze the whole thing, you know, take MPFL, calculated TDDG, and general valgum. So what else can you do? So you have to solve more problems. So this is quite crazy on femoral osteotomy. So this is quite interesting because remember what Shital said, the lateral side is so tight. So you do a very nice lateral release. And you think it's ingenious, Shital? I use the ITV as my graph for MPFL since I'm releasing it so thoroughly. Oh. So to 10 mm. And then when we dissect all the way down to intermuscular septum, and I prepared the tunnel, but because you're doing general valgum, so you also had to prepare the other side. So I think Malik did with me, this one I can't remember. So it's quite funny, as in I tell him that make sure that you don't drill my MPFL tunnel into the femoral osteotomy site and all the screws. So missing the screw, missing the tunnel technique, quite fun. And after that, you do your tracheoplasty and then complete the CTO at the same time. Yeah, and this is what post-op, all sort of horrible, what you call implants. But fortunately, we didn't get much stiffness again. So very lucky because it's very young patient. Yeah. Okay. So I quickly move on the clinical scenario last, and this is like the case I show you, really become chronic. Okay. And they also, you can see every time flex, it dislocates. So the patient had extension lag, and again, it's no definite trauma, not like recurrence, but really it's like a habitual became chronic. So you can see this fantastic thing. You can look at this, and what do you see? Like nothing here. Okay, when you flex, there's no patella here, because the patella is here. All right, it's beautiful. All right. Okay, so there you go. So here it is. Shital, TTDG is 4.7, and therefore I went up to do femoral version and tibial version. It's definitely more than 30 degrees off. So it's very telling. Your TTDG and your version, tibial version correlates. You see. So this is a very nice discussion with parents. I say blah 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 about this. Femoral osteotomy, tibial osteotomy. I correct everything nicely for you. The father asked me, isn't the problem in the knee? Why are you cutting the thigh bone and the leg bone? So finally, all the discussion, they say, no. Can you do everything in the knee since you are going to do lateral release and MPFL, all that? So we say, okay, we try. All right, very interesting. Come down. So you know the problem, very small patella, short quadricep. All right. So here, the trochlear dysplasia is not as much because the quadricep length is a more problem, and the lateral tibia is worse. So this is what, nice dissection again, really might be the lateral, what you call intermuscular septum. And again, I try to go and look at the, re-dissect and then to see the iliotibial band. And then again, I use that as a graph for MPFL later. And you can see that you release so thoroughly that it is nothing much left on the lateral side. And because this one, the quadricep length is really tight, really short. So it's a huge Z-plasty. You can see that at least, I think, 4 centimeters, I would say, yeah, to come down. So half a patella is gone. And you can see that. So look at this crazy thing is, when I did the TTO of 15 mm, Shital is still dislocate inflection. So I have no choice but shifted all the way to 30 millimeters. So you think it's crazy, and it could be done. And surprisingly, this patient was okay. So so in the end, it's nicely reduced and rather stable, So with crazy, right? Now it's 30 mm and seem to be survived that way. And again, this our CT scan pleased the parents tremendously. Okay, you can see that before, I mean, this is before on the contralateral side and it's after. So this really nice result this way. So any comments?
Did you do a trochleoplasty on this one?
No. As I say, the risk benefit, because this trochleoplasty is not so bad because I feel the flexion type and with quadricep tightness, I feel that their trochlea are usually not as horrible as the high-grade J sign in the extension type. That's just my observation so far.
Yeah, the only difference with the quadricep plasty is, as an approach, when I go in, I do the lateral lengthening so that I don't leave a big void on the lateral side. That I've done lately in the last 3-4 years, and it has worked out well,
But those only for not so severe cases. I found when such severe case like this one, you can see that, like you can imagine the, the TTGG is so crazy. It means they are contracture, all that, quite crazy. And then when I try to do the lengthening, because I, every time I try that, I ask a fellow to let's try this something new. Then I found that I barely lengthened and really had.
Yeah, you may not be able to, fill the entire void. It may be just a strip, like on this side. But I mean, these are tough cases. I'm glad that you have good results. Doing quadricep plasty and TTTG. One of the reasons to have an increased TTTG, besides the lateralization of the tubercle, is the rotational issues. If you have the femur is internally rotated and the tibia is externally rotated, that's going to increase your TTTG just because of rotation. So, you try and compensate, by doing a TTTG, but in actual, in real life, if you think about it, you're trying to fool the tibia thinking that you have, medialize the tibial tubercle, but in theory, you're actually increasing the external tibial torsion if you look at it, So you have to be careful about, about medializing in these patients. I mean, I'm glad that this patient has done fine, but, and these are tough cases. So there is not an ideal answer, like this is how it's supposed to be done. It's just, a lot of these decisions, I get consent for everything, and then I would decide intra-op, whether I need to, how much I need to move or what else I need to do. And, you just have to be prepared with your plan, that this is what you want to do. And sometimes you may have a little bit of variation what you end up doing.
Yeah, no, I did discuss, as I say, the parents about, whether we should actually do a TB osteotomy or that, but they saw absolutely decline on this. So end up had to do this crazy 30 mm, which is, I thought it's really doesn't sound logical at all. I mean, it's against any common sense, I feel. Yeah. But one thing I want to ask you, very interesting. I took almost half of the, quadriceps from patella superior border, but patients seem to do fine. How is that so? I'd like to ask.
That's the way I have done lengthening. If I have to do it, I do a sagittal plane Z lengthening. I take down on the patellar side, I take it off from laterally to decrease the lateral pull, and then further up, I take it off medially. But still, you're once you get it flexed, and I fix it at around 90 degrees, so you still have everything intact. You have taken down half, but just like you would do a Rugose weight, you take down half the tendon and you don't notice any significant decrease in the extension.
But Rugose wave are in the kids, you see. These are very big, 17, 18-year-old, I'm just quite big size, you see. So I'm very puzzled by why.
No, I'm obviously concerned. Whenever I have to do lengthening, I'm always concerned about extensor lag and weakness of the quads. But in theory, they have worked out well. It's just that you want to do it only if needed, like only if you can't get to 90 degrees, So I would do it only in extreme cases.
No, I'm more worried about them rupture altogether, not just the quadriceps leg, you see. Yeah. Okay, so just move on to my so this is kind, see the typical is quite thin, and yet it seemed to be okay. So surprise. So lastly, we talk about malrotation. So we always talk about anti-version of femur, you get and the sort of tibia, you get problem. But here, I just show you a very weird case where a patient had a definite retroverted femur, which by right is against the principle of patella dislocation. Okay, can he walk? Oops, video is not okay. But I'm just showing you that very funny, Shital, the entire lateral condyle is all ulcerated, So it's damn weird, by right retroversion of femur shouldn't get this, okay? And none is operated by, so we did the derotation and valorized, and the champion is called Malik. You can see that did everything. Okay, so for rotation, I always use a fixator assisted to help me to rotate, and then finally we did the varus osteotomy plus the rotational of the femur to solve this. Okay, I think that's all. Yeah, thank you very much.
That was great. A lot of interesting cases and a lot of complex cases as well. So should we go on to some, how much time do we have? We can move on to some complications.
10 more minutes, you can show, we can discuss your complication. I stop share here. Yeah.
Can I just ask a question, sir?
Yeah.
So lovely complex cases. That was great. So I wanted to know, like when we are doing all these other soft tissue procedures, do you always necessarily have to do an MPFL with it? Is it compulsory?
Excellent question. For patients who are of that age, you are not talking about the fraction in those like Rugose wave kind of age. That one no issue. But the moment I find adolescents, I really need the MPFL as my like neutralizing screw, in the AO contact, AO concept. So it's just there to neutralize and stay there, keep my house locked. That's all. It's not doing mainly pulling, but keep my house locked. Otherwise, in the end, I found it's still unsafe. Yeah. Shital, is that your opinion?
Can you see my screen?
Yes,
Yes.
we can. Shital.
Yes, Shital, we can.
Okay, all right. I'm just going to, we have another 15 minutes and we'll just go over some complications. Are there any questions from the audience that we can take as we transition to complications?
So one of the questions, Shital Jayan Sampat from Bangalore, he's asking, when patient has torsional problem with patellofemoral instability, what do you address first? Will you do osteotomy first, or will you realign first and then do osteotomy later on at second stage?
Okay, Shital, you answer that.
So that's a very good question. You have to evaluate the patient and see, if they have unilateral instability. I know I've got tough time explaining that, unilateral instability and their bilateral torsional problems. I don't know what is contributing or how much is contributed by the torsion, since they have the same, and usually torsion is symmetric. You can have a little bit of variation. So, one of the worst things is to correct torsion on one side, that would correct instability, but they would have asymmetry, with their gait, and a lot of patients don't like it. So if their other limb was normal and you've corrected the torsion on one side and they still have torsion on the other side, they would have asymmetry, and even cosmetic, that would be an issue. So, but if you have it, just a unilateral torsion issue and instability, you'll have to see how much of an instability is from the torsion. Means, whether it's a high-grade instability, then you probably need to address it. But I'm more inclined to address it at the knee joint doing an MPFL, because it's for me, it's less morbidity. And you can, when you're doing MPFL, you can get away with some degrees of, risk factors, all risk factors. Like if you have minor alta, if you have minor dysplasia, if you have TTTG, which is borderline, same with rotation. The issue with rotation is you don't know what is normal, right? Everything that we look at, they're different. There is no normal. How much of anteversion is normal? But if you have severe anteversion, then I would be inclined, and I would show you a case about it, in these complications. But severe to the extent that the patient is having gait issues, not just instability issues, like significant foot progression angle, internally rotated, and it's apparent, it's not compensated, then probably you need to address it. It's a tough decision. If you ask me just yes or no kind of an answer, my go-to technique is doing an MPFL and explaining to the family that if it fails, you'll have to address it. But having said that, I've not had to go back in to address it in any of my patients, even if they have some rotational malalignment.
So I just add on a bit. On that is that rotational osteotomy was first performed and popularized by Peter Stevens in even the 80s and 90s. But you can see that why it never caught on, unlike his another invention, guided growth, the A plate that he invented, right? The reason is really people feel the risk benefit was not as much. Number two, also they could not really identify the normality. Plus, I purposely show you the case of retroverted femur, which by definition, you shouldn't get a patella ulcer, you see? But yet in this case, retroverted femur has a patellofemoral problem. So that's why
I agree. And if you look at the literature, Lonnie Paulos has an article, exactly same question. When they did half of the patients, they did derotational osteotomies, and half of them they did not. And they found that patients who had derotational osteotomies actually did better than the patients who had either tubercle osteotomies or just stabilization. So the issue is the risk, morbidity, complications of doing a big surgery. So you have to adjust that risk-benefit ratio. The right thing to do is to do a rotational osteotomy, but you are trying to see if you can get away without doing it by doing a local procedure. So I hope that that makes it a little bit clear in this. The thinking process doesn't make it. The answer is not that clear.
And
right, so
age matters. So of course age. So if there is a child 9 or 10-year-old and who has habitual dislocation of patella, So you want to operate earlier or later, or if you operate earlier at age of say 8 or 9, is there higher chance of recurrence as in other, in rotational or angular problems, there is a risk of recurrence. So is there a risk of recurrence? So what is the preferred age for surgery in those patients?
So you're limited with the type of procedures you can do in a younger patient. Like you can't do a TTO, you don't do a trochleoplasty, you don't, but at the same time, you have advantages, in doing it younger age group. Remodeling of the trochlea is, can be seen, in kids who are less than 10 years of age. The earlier you can get them repositioned, the better, the growth of that, the joint, or, the better the shape of the joint is going to be. So I always tell the family we may have to do adult type procedure, when the kids reach late adolescence, and I tell them for everything that we do, like for an ACL, for MPFL. When you're doing in younger patients, you don't know if it's going to stretch out over a period of time, or they might need something down the road. But having said that, it doesn't happen. I just tell them as a caution. But I've seen that patients do much better when addressed at a younger age, and I've seen remodeling as well in kids who are less than 10. So I would prefer to do it, at whatever age they present. I would not wait for, for a certain age to do the surgery. So younger patients are actually better for us.
One last question, and I would, from Indrail, he's asking from USA that if you have to correct femoral anteversion and the valgus in one osteotomy, do you do it in single osteotomy and plan it, or how do you do it?
Then you will have to do it at the distal femur. If the patient is on the younger side, I've not done rotational osteotomies for young patients, like with open physis. I usually reserve it for older age group patients because, if you look at the normal values of anteversion, younger patients, tend to have more physiologic anteversion. And as they grow, that can, gradually correct. So I would wait to do a rotational osteotomy in a younger patient. But in an older patient, if they have both, distal valgus at the femur and rotation, you correct both at the knee, just above the knee. That can help you with both. But I would caution a little bit, saying with that it's a little bit difficult surgery, to have a control over a small piece like that without any hinge on the medial side. So you have to be careful about trying to achieve too many things. You can do it, but it's technically a little bit more challenging than addressing one thing at a time. Because if you're just doing valgus, you have a hinge, so it doesn't make it unstable. And if you're correcting rotation, I usually do it more proximally at the proximal femur than distal, because the pieces on the side is small. I like the idea James said about putting an IFICS on to control the fragment. So you have to be careful. It can be a little bit difficult surgery.
Well, I have a lot of assistance, so that's why maybe I'm more privileged than you, Shital. So,
if there are no questions, I'll just go over quickly over some of the complications that we have seen. Let's see. Okay, so if you look at the outcomes, we did the systematic review of isolated MPFL reconstruction, and it's pretty good. Recurrent instability 1.2%, and reoperation risk is 3.1, apprehension in 3.6%. So overall, I think we have pretty good results with the isolated MPFL. But if you look at the complications, we looked at 179 knees, and we had 16% complication. This was early on in my career, the first 5 years. And there were fractures, there were recurrent instability, some stiffness, and some pain. But the thing is that when we analyzed each of these patients, went back and looked at everything, we found that 18 of these 38, there were technical issues which were preventable. That means that, say if you have a DVT, if you have a wound problem, if you have infection, sometimes you can't do much about it. There's not a whole lot of things you can do to prevent it. If it happens, it happens. But a lot of these were technical issues. So we went back and, we'll just look at the cases and how, things have changed. 16-year-old girl who had an MPFL reconstruction for recurrent patella dislocation using a gracilis autograft. And then 2 months post-op, she slipped on a plastic bag and she fell on her knee. And this is, she comes, she has now a patellar fracture. So James, my question is, if you have this, you have a patellar fracture after MPFL, 2 months post-op, why did it happen? What are you going to do now? What about your MPFL reconstruction? Because it's still there and that it's still a problem. So, any thoughts?
Yeah. So I think for I don't know what sort of tunnel you do use. Usually, I didn't like
I use the tunnels that you use, the same type.
Yeah.
Two tunnels, oblique.
Yeah. So I find that when I inherited such patient will be from other hospital when they came to see me, and usually I ask for a immediate post-op X-ray of their film, and then you analyze it, and then you find that usually the tunnel depth was a little bit cross the midline, and that's something I didn't quite like. So I always tell people you must have a 1 centimeter gap between when you enter, and also do not converge so much, and nor the tunnel went beyond midline. So very good to see immediate post-op X-rays if there's any.
So, and what would you do now?
Oh, now no choice but to fix. That's all. Yeah, because a lot of time the funny thing is that the MPFL a lot of time are there. That's very strange.
Yeah. So early on we had some fractures which we reported. This is a series of 5 fractures that we had. In this particular patient, we did a tension bend. The graft had almost healed to the tunnels. We reinforced it by suturing it to the anterior periosteum. So that's a salvage of the MPFL. We bone grafted the tunnels by using DBN, and then tension bend wiring, immobilizer. If you look at the follow-up, the fracture did go on to heal, but the patient had restricted motion, only could bend to 120 degrees. This is at 2 years, and had pain with attempted further flexion and no instability. So patient did well, but the outcomes were a little bit suboptimal. And that was true for all patients with fractures. They all had some issues down the road. So, the idea is how can you prevent this? And is this technical issue? It is a technical issue. If you have a fracture of the patella, that is something that is preventable. So we went from here. So we were using these kind of tunnels, 2 tunnels. We used semitendinosus initially. These are 4 or 5 millimeter tunnels, and they would cross midline. They would go past 50% of the patella. We would not use any implant, but we would loop it around the bone bridge. And then we changed to this technique. We don't do that anymore since 2012 or 13. This is what we have done is a gracilis autograft. We have used only 3.5 millimeter tunnels. I won't drill anything more than that. A single tunnel can just on the medial 1/3 of the patella with no implants and looped around the bone bridge, and no fractures in more than 300 cases. Just to show that tunnels, you can modify them. Whatever issues you find with your complications, if you analyze it, you can try and see how you can modify it. And we'll go over, because of the time issue, I'll just go over a few more cases. So this is an MPFL using gracilis autograft. Routine post-op physical therapy, but the range of motion only had 90 degrees at 6 weeks post-op. And if you look at the X-ray, that's significantly anterior malposition of the femoral tunnel. Okay, that's we talked about. This was before we used radiographic, confirmation of our tunnels. We used to open these on the medial side and use MCL as our guide to guide it, and we had a lot of anterior tunnels at that time. And so we changed it. This is the ideal point, and if you draw it, a posterior cortical line, and then you make 2 perpendicular lines, just like the Shital method, and your ideal point should be here, not where it is positioned. So it's way anterior than where it's supposed to be. And the issues or the causes of stiffness and the solutions are, one way to avoid malposition is to use fluoroscopy. When you're doing the surgery, we always use it. If there are chondral lesions, you can have stiffness, so you need to offload it, or you need to address the cartilage lesions. If you have increased pain, we use post-op blocks on all our patients so that pain can be better managed. Neuromuscular deficits, we have seen that if the patient, we had a patient who had a sciatic nerve injury from a block after surgery, and then that patient ended up with stiffness. So if anytime, we have seen it in other locations as well, like a supracondylar fracture with a neurologic deficit, they end up with some stiffness. So if you have neuromuscular deficits, then you would end up with stiffness. if we have over-tensioning of the graft, my final fixation is always in flexion and not in extension to prevent any over-pull on the graft. Range of motion is immediate. We don't do any prolonged immobilization. We have to make sure the patient understands the importance of physical therapy. So these are various causes. And we have a protocol for stiffness that we want to achieve 90 degrees by 3 weeks and 120 degrees by 6 weeks. And if we don't achieve it about 120 degrees, then we would do a manipulation under anesthesia. So we are very aggressive about doing it. So all the 8 cases that we reported as complications were these patients who did not achieve 120 degrees and we manipulated. You can say that if you wait a little bit longer, they might get more motion. But if they don't, and if you're beyond 3 or 4 months, then there is no option but to do a lysis of adhesion. You can't do a manipulation at a later stage. There are more risk of having fractures and not achieving what you want to achieve. But if it's recognized more than 3 months post-op, then I would not manipulate it too much. I would rather do lysis of adhesions. And we haven't done that. I'm just letting you know this is the protocol. And if they don't achieve full extension by 6 to 8 weeks, which usually by 3 or 4 weeks they should have full extension, then I would initiate serial casting. In short, you do everything to prevent an arthrofibrosis. You can call it a little bit more aggressive because I've seen, during my fellowship and training that treating arthrofibrosis is a significant issue with a lot of suboptimal outcomes rather than trying to be a little bit more aggressive up front and not having to deal with arthrofibrosis. So we have not had any issues lately. These complications were reported early on in the series, but we have changed the way we manage it, and this is the current protocol. This is the 3rd case in MPFL reconstruction, and 2 months post-op, the patient had increasing pain over the medial femoral graft site. It wasn't controlled with NSAIDs and local modalities. So that's another point is hardware on the medial side where you used to put the screw in. If you look at the MRI here, you see so much of edema on the medial side, whether it's because of the patient being allergic to the screw material or hypersensitive to it. Anyways, we went and removed the screw and everything resolved. In this patient, it wasn't prominent, cultures were negative, and the graft had almost healed. We just did some suturing to the periosteum and symptoms resolved. But the main point is that any hardware on the medial side, when we put it in, we do it percutaneously. You always check with the fluoro, make sure it's completely inserted because any prominence on the medial side is not well tolerated. So make sure that your hardware is not prominent. So this is, I would go really quick. I just want one message out of this. I had seen this girl, 13-year-old girl who had a lateral-sided knee pain, had no instability. She was treated conservative for 4 months. She wasn't improving. She had some relief with cortisone injection, and her diagnosis was a lateral patellar hypercompression syndrome, and she underwent an arthroscopy and lateral release. After that, she developed patellar instability. She never had instability to begin with. 4 months post-op, she said, "Oh, my patella is subluxing now." She went ahead and did an MPFL reconstruction. 4 months later, she had medial-sided knee pain, and she underwent debridement of some scar tissue. Her MRI was normal. 2 years post-op, she continued to have instability. So we did, MRI, which showed that the graft was stable, and I thought it may have stretched in spite of, the MRI showing an intact graft. So we revised it with an allograft. And we use the same tunnels because tunnels were in good position. So this is a revision thing. 1 year later, she had increasing pain. So we did a Z-lengthening of the graft. We thought it was too tight. 1 year later, she had continued instability. We did a tibial tubercle osteotomy. Okay, these are the surgeries that I've done on this patient. 8 surgeries since her initial lateral release. You can look at the dates on the left side. Starting in 2011, every year there is a surgery done by me on her knee. So what she actually had was medial instability. Okay, she always complained of her patella subluxing, but you take it for granted that it always subluxes laterally. And it is my fault that I didn't recognize it. The last surgery I did on her was a lateral patellofemoral ligament reconstruction for medial instability. That solved her problem. It's more than 2 years now, and I'm in touch with the patient. She said that she feels fine. She had never felt this good before. The idea is that the reason that she had medial instability was a lateral release, which was the first surgery she had. And after that, when she presented, every time she said it was going out, we always assumed that it was going out laterally, in spite of the MRI showing that there was no bruise pattern, the graft was intact. But we have to believe the patient. It's just that the patient doesn't know which way it's going. It may feel like it's going out, but it's actually a medial instability. And the reason that, if you look at medial instability after lateral release, it's very difficult to diagnose because that instability is not a frank instability. It's not like the patella is going to dislocate medially, but they would complain of pain, they would complain of subluxation, difficult to diagnose. But I know after these many surgeries, I went back and looked at all her op notes, and I realized the first surgery was a lateral release. And that is when I, gave a trial of, bracing, gave a trial of taping. And every time I tried, she improved. She said, this feels really good. So I did a lateral patellofemoral ligament reconstruction for medial instability, and that solved the problem. So the message is never do an isolated lateral release, for instability. But probably the diagnosis of a hypercompression syndrome was wrong. And if you are not really sure about it, it's better to do a lengthening rather than a release. But for instability, never do a lateral release. I've this one patient I've learned, that I'm going to skip over this because we talked about it. But this is, addressing the genu valgum that James was talking about with the transficer screw, and we have reported on some patients. This is the last case I want to talk about. So you can see the type of dislocation that this patient has. It's not a typical dislocation. The patella has not just slid out, it has actually everted. Okay, it's a 15-year-old boy. He had a quadriceps plasty similar to what I've done for my patients at an outside location, at an outside hospital for habitual dislocation, and he came in because of recurrent dislocation. And if you look at the patella, what has happened here is that it has spun out. Okay, it is not a straight sliding out, but it has spun out of the groove. And the reason this happens is because there is significant overpull of the medial flap on the lateral aspect of the patella and makes it spin out. So if you look at, this patient, we did an MPFL reconstruction after that, and that was enough. But when I do a quadriceps plasty, we will do a medial and lateral arthrotomy here. We'll reposition the patella. We'll bring the medial flap over and suture it to the lateral side. Now, when you do that, that is when you can have issues that the medial side can cause the patella to spin. So what I do is I put a suture here to hold the patella in place on the medial side. And the second thing I do is I do a lateral lengthening so that I don't have the patella spinning out on me. And if you look at clinically, you can see that suture right there. I use the suture before I bring my flap over and suture it to the lateral side. And you can see the lateral lengthening flap. It's not covering the entire void on the lateral side, but it's something to keep my patella from everting. Okay, so it's never going to be a good lateral, because if you've done enough lateral release, like good enough lateral release, you cannot do a lengthening and get everything to be sutured back. But you can get some tissue to come up and suture it, so you have some stability in that way. And oh, I have one more case here. Okay, so this is a bilateral medial patellar subluxation kid, no previous surgery. The symptoms were to the extent that she was wheelchair bound, and all her spine examination, neurologic examination, she even had a muscle biopsy that was normal. So suddenly when she hit adolescence at around 13, 14 years of age, she became wheelchair bound. And when she came in, she said, my patella is subluxing medially. And I've seen that, when you have significant rotational issues, your patella may seem like they're subluxing medially. So she went, I said, we'll rehab it, we may have to consider osteotomy. But she got a lateral patellofemoral ligament reconstruction at another hospital because the patella she was convinced it was medially subluxed. So this is a lateral reconstruction that was done somewhere else. And she continued to have issues. She had recurrence of symptoms. She came in and she said she needs a revision of her lateral patellofemoral ligament reconstruction because this one failed. And I said her problem is not that it's the patella is subluxing medially. Her problem is the rotational issue. So we ended up, evaluating her. If you look at the full length X-ray, you see the AP of the pelvis and the AP of the ankle. But look at what is happening at the knee joint. That's significant rotational malalignment. So that is where I would do the CT rotational profile and correct, both the femur and the tibia. This is how I've done it at the trochanteric level on the femur and supramalleolar on the ankle. And I usually do bilateral. And that allowed her to be independent ambulation at 2 years follow-up, so she did great after that, no other issues. All right. Thank you, everyone. Let's see if you have any questions or we run out of time.
So Shital, why you didn't do proximal tibia?
Sorry.
Why you not doing in the mid or proximal tibia for rotation?
That's a good question. So, then it brings up a question whether you're going to be doing it supra above your tuberosity or below your tuberosity. And if you're doing it above the tuberosity, you'll be shifting your TTTG at the same time. And in doing it below, I think you're getting into the shaft area. So, I feel it, a little bit more easier for me to do it when doing it supramalleolar. It's an easier surgery technically as well for me.
No, but because by right, the standard for that, people actually do it using a nail to correct at the sort of mid shaft of tibia. So they avoided going to.
So I don't think that there is, when you're addressing torsion, the torsion is along the entire bone. So there is no there is no apex, or like when you're doing, there is no pora when you're doing torsional deformity correction. So you can technically correct it at any level. The advantage of doing it in the shaft would be immediate weight bearing when you're doing your nails, and the only issue I had is because I've, anyone who has done more is Taiji, and I've seen a lot of his cases, which he was sharing with me, that were done at an outside hospital, went on for delayed union, non-union, when you're doing it in the shaft. So I'm kind of, a little bit concerned about, doing it at the shaft, but I know a lot of people do it and not have issues. It's easier, like, you do it percutaneous osteotomy and, you lock it then proximally and distally. But for me, this has worked out well, to do it in the metaphysis, so I don't have to worry about healing.
Okay.
So Shital, we have a question. Can we have a question, James?
We're more than 2 hours already,
So we have one question. I think we should satisfy the listeners also. So there's a question from Kailash. He says, when you're planning MPFL reconstruction and TTO, would tracheoplasty be in the preoperative plan or an intraoperative decision? Because it's a morbid in exposure as well as procedure per se.
I have never done a trochleoplasty as an intra-op decision. Trochleoplasty is a big surgery. If I'm going to be doing it, I would think about it and plan it. James said that he does both at the same time, the trochleoplasty and tibial tubercle. I usually just, I've done both in, I remember one patient I had to do both, and that was a very similar patient to what James was showing, habitual dislocation in extension, significant high-grade dysplasia. But majority of the patients, if I have to do trochleoplasty, that should correct my TTTG, because you're not moving the TG, but the trochlea TT is what, your trochlea is what you're moving. So it should correct your TTTG distance. So I usually don't combine it. And the other thing is I rarely ever do a trochleoplasty in primary cases. I always use it for revision. So, if you're doing it primary case, I would, it's easier to do a tibial tubercle osteotomy and an MPFL than doing an MPFL and a trochleoplasty. So, if you haven't done much, or if you're not doing too many of these, I would stay away from trochleoplasty. And, you hardly would have, you may have 2 patients out of 100 that might need it.
Yes. So I hope that has answered the question well. Yes, James, do you want to add something to this?
No, that's all. My computer only 6% left, so I.
So okay, I think we had a great session. And
if they have more questions, I'm happy to sit around. If there are more questions to be answered.
Avi and Chintan, you have any questions? On WhatsApp, I had only one question.
No, anyway,
okay, James, I think you had a long day. We understand that you had a.
Before I say goodbye to everyone, I really enjoy all your presence, and I hope after this COVID over, I would receive all my fellow from your esteemed country again. And I must like to share what I observed today in the cases we presented. You guys must learn to differentiate between so-called 2 masters. The pseudo master show you all his complicated cases, but true master like Shital show his complications. So now you know.
No.
Thank you very much.
So James, that shows your humbleness. We appreciate James. That. No, I think it's good to know that sometimes you don't know that you may have a patient who is very severe. And I think it's good to learn that this is the one, it is not for you. I think that's a very important lesson that, you know, you have certain surgical armamentarium possible in your setup and your training, which allows you to do that. And if there is anything beyond that, it may be a good idea to go to an expert who is routinely doing this. So I think we will excuse you and thank you from our side, from IFICS and OrthoTV side, that you were we had a great opportunity to learn from you, and we appreciate your honesty and humility. So with that, we'll excuse you and we'll continue with Shital. Have a nice day.
All right,
Enjoy
James.
your Sunday evenings
Bye-bye.
with the
Good
family.
night. Good night.
Thanks, James.
I understand in the old age, but now when you see children less than 8, the really young age, so do you feel just the growth modulation is enough to correct not just the valgus, but even the patella instability, or would you even add something else for that smaller age?
So it would depend on the type of instability that you're dealing with. If you have someone with a complex pattern, which is habitual dislocation, that would not be corrected with correction of just your alignment. So if you're talking about an 8-year-old, it's very likely that they would have a complex pattern, because the episodic pattern where you have your first dislocation and then you have another dislocation after a year, that pattern usually starts after 10, 11 years of age. The younger patient may have more complex situation where just doing a guided growth is not going to be enough. Having said that, if you do have a patient that has only one dislocation or two dislocations and is 8, you can certainly correct the valgus and see if that solves the problem. I have issues just correcting valgus to solve instability issues for the reasons I had mentioned before. That if you look at the literature, they continue to have some apprehension. They have half of them continue to have instability. So valgus may be a component that's adding to that instability, may not be the only cause of the instability.
So Shital, can I ask you, what was the youngest age you did a trochleoplasty? Because we being pediatric orthopedic surgeon, having distal femoral physis open, we are a little scared to go ahead and do it, even if we find suitable patients on preoperative assessment.
My youngest patient has been 14, and there is a report from NELITS. It's on doing trochleoplasty in adolescent population with open physis, and they have not seen any growth arrest. It was a big series, and I know him personally, so I would trust him with his reporting. So I don't think it's going to be an issue if you're addressing during late adolescence, 14 or above, even if they have open physis. But I wouldn't go. So if you have a younger patient that needs trochleoplasty, there are different types of trochleoplasty that could be done in younger patients. Like if you do an LB trochleoplasty, it was meant for older patients, but that could be done safely in younger patients without violating the physis. It's a lateral, elevation trochleoplasty. I've seen it. I've scrubbed and assisted surgeons during my traveling fellowship doing it, but I have not done it myself because I don't find the need of doing, a trochleoplasty in a younger patient.
So that was a very nice thing to learn, because our exposure to trochleoplasty is hardly any. So
yeah, I would not even go. I would not even consider trochleoplasty. For as I said, majority of the patients are going to do well without it. Only those who are recurrent dislocators, like failed one surgery, failed a well done MPFL, and has a very big bump or something, probably you might have to send it to someone. But if you're doing just very few, like if you're going to be doing one in a couple of years, may not be a great surgery to learn or to do it.
So continuing from there, suppose you have done a child who is around 10 years old with a habitual dislocation of patella, where you felt that the trochlea was shallow, but the patella was sitting well and then tracking well. Do you have any experience of doing MRI at couple of years down the line and see how the trochlea developed in such cases, patients where there was a significant growth left?
Yeah, we just published, actually. It was in JPO, MRI after MPFL in younger patients. And we saw that for those patients that were less than 10 years of age, when we stabilized them, they did develop the trochlea grew much better. So we had a follow-up MRI on them. And it was, I think, more than 10 patients. The only time they would not there was one patient in that series which was an older patient, and that patient had no change in the sulcus angle. So that is where we said that, probably, and even the literature otherwise has 10 or 11 years as a cutoff age, after which, when you reposition it, you can stabilize it, but you don't expect remodeling of the trochlea. But prior to that age, I've seen it, when we have reported it on follow-up MRIs that do tend to develop, better grooves, if you stabilize them early.
Okay. So I think we'll go on to Avi or Chintan if they have.
Yeah, other thing, the laxity was not discussed much today. So about how would that affect your management?
So that's a very good question. If you look at some recent papers, it has shown that laxity has decreased, patient outcome scores. After successful MPFL, that means they didn't have redislocation, but they still had inferior reported outcomes, compared to those who didn't have laxity. From a technical standpoint, if the patient is significantly lax, I would tend to use an allograft compared to their own tissue, just so that it doesn't stretch out. Or if they're against an allograft, then I would use a SAMI-T instead of a gracilis, because it's a little bit bigger graft than your gracilis. We do Beighton scores on all patients to see for hyperlaxity. One of the things that I'm interested is whether they can touch their palm on the floor, because that indicates that hamstring can be stretched significant. Then I would be against harvesting their hamstring. If they can put their palm on the floor with the knee straight, that means they have significant, laxity in their joint, especially hamstrings. Then I would not, I would not harvest that hamstring. I would, and you have other options. You can use your quad tendon. You can use allograft, we just looked at our Ehlers-Danlos patients. We were just looked at all the results of them. We have not yet published, but we are just compiling. We have not seen any significant difference in redislocation rates with allograft versus autograft. Even though I'm saying that I would use an allograft, we have not seen, even with autograft, we have had good results. So it hasn't affected the redislocation rates, the MPFL reconstruction in lax patients, but it has shown to have a little bit less relief of symptoms. When you're talking about patient-reported outcomes, they are scoring a little bit less, but they could be, from the pre-op, that lax patients may have some other issues, either pain control issues or other morbidities associated with it. So we don't know, but that is what it was reported by Heemstra from Canada. She had a good series. Everyone had pre-op and post-op, scores. And those who were hyperlax had less post-op scores compared to those who did not.
So Chintan, any questions for Shital?
Yes, so continuing with the guided growth. So when you're doing guided growth with MPFL, as it is required in immature skeleton, how will, because if you're doing with 8-plate, then your epiphyseal screw and even your screw for your MPFL fixation will be very close to each other. Probably MPFL screw will be a little posterior, screw will be a little anterior. So how will your sequence of surgery go and sequence of your placement of screws?
So, I agree with that, your MPFL, insertion is very close to your plate. So whether you want to, do a posterior fixation of your MPFL, or in the past, when I was using the plate, I have even tied it to one of the plate screws. When I'm putting the screw, I would tie my MPFL graft to the inferior posterior screw of the plate. If I'm using an H plate, which are 4 screws. So you can do it. I wouldn't recommend putting the plate on the MPFL, because that is going to shorten the graft significantly, and that is detrimental to the pressure in the patellofemoral joint. That was initial. Now I'm doing a transficer screw so that I come from the opposite side. It doesn't interfere with my MPFL, and I've done in more than 15 patients. We have reported them in JPOB. We, published our series of transficer. I find that it doesn't come in the way of my MPFL reconstruction like a plate would come. So that's what I do it now.
So I think that brings us to an end of a wonderful session on patella. I think it's very important the way you started, that the classifying the problem is a very important thing. You should not classify recurrent dislocation with habitual dislocation, which has a significantly different treatment. And when you are choosing a patient to treat for uh, 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 habitual dislocation, which comes quite common to a pediatric orthopedic surgeon, you need to check whether that patient has any syndromic issues, because they are more likely to fail. And if you are venturing towards adolescent age group, you are likely to get you're going to get more of a recurrent dislocation type of picture, and you will require MPFL reconstruction more common. Otherwise, your procedure, which is a modification of insole technique, will be very suitable to the most of the pediatric orthopedic surgeon who treat more commonly the habitual one rather than the recurrent one. So having said that, I would like to thank you from IFICS side. You are one of the IFICS members, but just to be an officially speaking from India, I would like to thank you from the IFICS family for a wonderful webinar. And we would like also to thank you to be instrumental to bring fantastic faculty to IFICS webinar, which is going to be held in September, and the registration of which is all open on ifix.in. We encourage a lot of young people to attend this, because this is going to be a seminal conference on pediatric trauma, with who's who of pediatric trauma coming under one roof, probably for the first time speaking only on pediatric trauma. I'm sure they will come on one platform for a pediatric orthopedic problem, but hardly ever come only for a pediatric trauma conference. So this is going to be a landmark conference, and we would encourage you to take part in this, and we'll be very happy to bring it over to you in a very nice way with the active involvement of Shital and his active efforts. So with this, I would like to conclude and have a nice evening, whatever evening is left for this Sunday. Thanks a lot again.
All right. Okay. Thank you, everyone. It was great to be with you all. Okay. Bye-bye.
Okay. Good day, Shital.
Okay. Bye, Avi. Bye,
Bye,
Chintan.
bye, Zavi.
Bye, everyone. Bye, Premal.
Bye.
Bye.